Radiographer-led Oncology podcast. Welcome to a bonus episode to round off our Podiatry special week. My name is Julka-Anderson and I'm joined by fellow host Jo McNamara.
Hi everyone.
So we're very pleased to introduce our guest, Afni Shah-Hamilton, who will be discussing her role as a podiatrist. Hi Afni, how are you?
Hi, I'm good, thanks.
So, I'm sure everyone's been wondering why we've been posting lots of interesting photos across social media last week. Can you tell us why you like feet so much and how you got into a career in podiatry?
I'm quite passionate about feet. So anyone who speaks to me is your feet carry you everywhere, basically, don't they? So you use them every day, and we all just take them for granted. So everyone looks at their teeth and is always obsessed about your teeth and face, but actually, you can replace bits of that, but you can't replace your feet. So that's one of the first things. And how I got into it, so I have a specialist interest in wound care. So early in my career, specialised in wound care, even at university, really interested in it. We got to see leprosy patients, so that was really cool. And then from there, I was working for Southwark, which had a conjunction with Guy's and King's Hospital. So again, lots of wound care stuff. And set my own private practice, Tiptoe Foot Care then as well. And then started getting vascular referrals in for vascular ischemic ulcers, so where there's poor blood flow, not healing. And again, they see a lot of diabetic patients. So that natural course of wound care, not actually getting the right treatment, and things weren't healing. So then they basically would send their patients on to me. And they went and spoke to their oncology team, and the oncologist started referring in patients. And from there, started off really small, starting to see really random oncology symptoms of nails and skin conditions, and then just built on there. And so that's how I ended up my passion in the effects of cancer in podiatry. And so I've been bashing my head a little bit against the wall, raising the awareness that actually this is a super important issue, because as you can see, there is a wealth of knowledge, and I now sit and advise for Macmillan and a number of other things as well. So I speak for the Institute of Prophetess and Podiatrists on it as well, and cancer effects. And so it's just built from there. And then also with that comes complex pain issues as well. And so with my musculoskeletal knowledge as well, again built with that, and then done a lot more other therapies to actually complement what I do in my clinic. So my clinic is pain management, but also cancer focused as well. And that's how I kind of came about with it. But I am very passionate that patients should not need to suffer in silence and shouldn't be ignored and being given wrong advice, because there's no excuse for it.
Yeah, Afni, can you tell us a little bit about kind of podiatry as a whole? Do you have to specialise in a particular area? Do you study all pathologies relating to podiatry?
So podiatry is now a university degree, so you go to university and you do it. And also, everyone gets confused with chiropody and podiatry. They're exactly the same. So previously it was known as chiropody, and now more internationally it's known as podiatry, and it's, again, we've adopted it now as podiatry. So now if you go to university, you get a degree in podiatric medicine. So in your course, you basically learn the vascular system, neurology, pharmacology, all the specialist knowledge with the feet as well, but also all the systems of the body as well. So you have to know your anatomy and physiology as well, but also much more intricate. So I know it sounds awful, and I keep comparing it to dentistry. It's basically you're learning the whole system like you do in dentistry, and then you have your specialist clinics like in dentistry. Same thing, specialist clinics in podiatry. I've kind of split it into three main areas that we kind of look at. So, and even then you can split it further. But you've got your musculoskeletal side of things. So looking at your walking patterns, insoles, foot pain, sports injuries, all that you can go into. You've got your derm side, so dermatology, which is skin and nails, all the things that react with that. Wound care is particularly prevalent in those patients, particularly ulcerations. And then you've got your vascular side, which again, circulation issues, and neurology side, which is your nerve sensation. So again, we're always testing for, in terms of neurology, early detection of changes to your sensation. So your light touch, your vibration, hot and cold, pain. Also, you're looking out for some of the autonomic symptoms, which are rare, but particularly as we know for cancer patients, that actually can be more of a risk than other conditions. And then in terms of the vascular, again, we use things like the Doppler ultrasound. So you're looking at listening to the blood vessels and the quality of the blood vessels. how much flow is going there. You're looking at the venous returns, you're looking at the lymphatics, again, the edemas, because that has an indication of high blood pressure issues, or the blood pressure is not being monitored correctly, or again, these irregular heartbeats, there's an irregular pulse beat in the foot, there's going to be something going on cardiac wise as well. So that's kind of what the broad sense of podiatry is. But basically it's any conditions from the lower limb, you know, so anything that comes in we can see and treat. So that's kind of what it was. And so, yeah, you can specialise in different areas. So some specialise with diabetes, some specialise in rheumatology, vascular, but that's kind of where it is. But cancer hasn't really been talked about or even considered, even at university levels. There's a lot of talk about diagnosing moles, which is great. And like in my clinic in the last month or so, I've already diagnosed 3 potential cancer carcinomas and things. But actually, that's a very small part of the cancer pathways. So, hopefully I've answered it.
When you qualify then, how do you build up your confidence in certain areas? Do you work in hospitals, clinics, private?
Yeah, so you can either go straight into private, or you can work in hospitals or in NHS community settings. So sadly, I think with the NHS the way it is, there's probably less specialty settings to be able to go into compared to when I graduated, which was, just over 18 years ago now. So when I graduated, there was a lot more in-house hospitals and things that you could go into, whereas now it is a lot of it's in communities. But again, podiatry's been one of the ones that's been cut a lot across the NHS. So that is a bit unfortunate. But you can go straight into private practice. So in my case, I had an interest in wound care, but actually, even though yes, I did quite a few clinics in the NHS, I actually specialised and got really into wound care from my private practice side, and that's what I was seeing. And also mentoring is really important. So going out and getting mentorships with people and speaking to people and advocating. I'm really lucky. I've got a really good set of mentors that I can liaise with and talk to. But I think that is also key, particularly now in the healthcare world that is changing in, and also what settings you're going to be in. And a lot of podiatrists will do a mixture of NHS and private practice. And you've got a wide range. So you've got the generalists as well, who will just see everything but not specialise in particular areas. And then you've got, like myself, who specialises in a few areas. So, yeah.
So I do... Oh, sorry, Joe. You unflicked. Go. So I do a lot of running, and I have runner's toes, which are gross. What do I do? How do I get support so that I can wear flip-flops and my wife doesn't shout disgusting things at me?
That's a really easy one, actually. To be honest, in the nicest way, you're not going to be eligible on the NHS criteria to see a podiatrist on the NHS. To be honest, pretty much if you're diabetic and your toes falling off, you're probably going to be able to see the podiatrist. But you can just self-refer straight into a podiatrist privately. What I do recommend is that you see someone who's on the HCPC register. So you can either Google onto the HCPC register, check that they're okay. Also, the Institute of Chiropodists and Podiatrists and the Royal College of Podiatry both have listings of podiatrists on there. So again, that's a nice, easy way for people to go. Again, you've got Google. Look at the reviews. And also, what I say to my patients is, particularly if you're looking for particular areas, ring up the practice and say, look, I've got this. Is it something you see? Is it not? Because again, you might see it's like a hairdresser. You know, some might be specialising with like curly hair, and some. So asking, do you specialise with this? So now, I mean, if you came to my clinic, would be yes, because we do the musculoskeletal side. So we'd also not just be looking at the nail issues that are going on, the hard skin issues, and but we'd also be looking at your gait and making sure that you're actually moving correctly, so that when you are running, you're not putting that same impact on your nails. In terms of the conservative treatment, we're treating the nails, all the issues that come with the nails, minimising that area as well, and giving you some advice on it as well. So we're treating actually, so runners often get the nails lifting, getting blistering under the nails, and the nails start to become deformed and quite thick, which then increases more pressure in the shoe, which then creates that cycle of pressure and more deformity. So we'd be looking at that. But also footwear is a really important area. So there's lots of myths about footwear. Again, podiatrists are fantastic at that. We know so much about footwear. And so in my clinic, what I'll be looking at is in terms of looking at the sole of the shoe. What is the shape? So often a lot of the runner shoes are actually known as what's on a curved last. So the sole starts to curl in a bit like a banana shape. But actually that's not great for runners because you actually need the shock absorption. So all these shoes that are saying antipronatory, well actually the pronatory mechanism is the bit that helps you absorb shock so it doesn't go into the knees and hips. So actually, so there's a lot to it, but also your shape of foot as well. So you might not be able to wear a particular type of shoe. So there's lots of materials used and everything. So someone may need more rigid sole, someone may need more a softer sole. So it really does depend. And so we look at all of that. So, but yeah, the easiest way is self-referral in.
I basically wanted you to say, don't look at your feet, Afni. I'm glad you didn't. You weren't lured into doing that because, yeah, before you know it, he'll be there going, what can you do with these? So, Afni, what are the typical things that oncology patients experience?
Right, so there's two areas. So let's go for the chemotherapy area first. So you've got the dermatology side. So you've got the hand, foot, and skin reactions, which can cause these really painful areas of hard skin on the foot, and it can be really painful because even the slightest touch to it, just trying to put your shoes on, it's just agony, and they ulcerate really quickly. And also because we know like 50% of cancer patients are typically diabetic as well, so they already are in that category where skin integrity can be an issue. So that's one of the other ones. And the other one is hand-foot syndrome, where you suddenly get these rashes on the skin. So the skin can turn, normally about day 4 after a cycle, it literally gets stained either bright red. So you've seen the pictures on the postings on Caucasian skin, but Afro-Caribbean and Asian skin, it's actually a much more purplish colour. But again, it can create blistering and fissuring. And these fissures just kind of split. So it's not like loads of hard skin, it just splits. And so you can imagine like you've got like massive paper cuts and you're walking on paper cuts, but all the way across your foot. So that's one of the skin things. And again, the other thing is nail toxicities. Nail toxicities are really important. They also happen in radiotherapy as well, but particularly in chemotherapy, and a number of drugs actually cause nail toxicities. And the nail starts to lift, and as it lifts, it ulcerates. And these ulcerations, again, patients get given the wrong type of antibiotics for the ulcerations, so they're not actually being swabbed properly and not actually looking at the clinical signs of what the wound looks like. So for a Staphylococcus aureus infection, actually you can tell there's different smells, it looks different, the different colour exudate, whereas a Pseudomonas, which can be actually much more common in these patients, which is anaerobic bacteria, it gives you these blue-green, and it's a different type of smell, and it reacts differently, and again, different antibiotic dressings treat it differently. Well, it's not antibiotic, antibacterial dressing, should I say. But particularly for nail conditions, again, you've got that lifting, but not just on the toes, on the fingernails. So you can imagine it lifting suddenly. It can be really painful just even to grip things with, because it's that constant, like a loose nail being pulled like on the area. And then you've got the ulcerations. You've also got the delayed effects of the nails getting distorted as well, so they can become thickened, and they can also become have fungal nail infections, again because your immune system's down. We've got natural skin fungus on our bodies. The thing is, they're opportunistic infections, so when your immune system goes down, they take hold and they infiltrate into the nail plate and start to distort it. So you've got the long-term effects of like thickened nails, the fungal infections that come with, but then also the acute side of things, so that immediate effects that happen are the ulcerations, and yeah, wounds, and just basically nails just coming away. So you've got that. In terms of the radiotherapy, again, you've got the skin conditions, the abnormal dry skin that people talk about, and the nails. And then we've got the neurology side. So both can cause induced neuropathies, and there's loads of literature around it. It's actually even less literature in terms of what, and I've been researching about it, the radiotherapy side, but it is more talk about the chemotherapy. Even then, it's still not exposed to actually the levels of what, it's quite debilitating. It's that burning sensation conditions on the foot, that light touch. So again, your foot changes can happen. So because you can't feel, your foot starts to alter around it, you can get more damage to the area. Again, patients often find when they've got sensation issues, some can't feel their shoe on their foot, so they start to go for a tighter sole. Whereas when you've got like the dermatology issues, you're going for a much more looser thing, but then you've got slipping going on, you're getting damage elsewhere. So the two can have an interesting situation goes on with them. So you've got the neurology, then you've got the musculoskeletal, which I don't think gets talked about at all. So regardless of whether you've got neuropathy or a dermatology issue, it can cause pain. That alters the way you walk. You know that if you stubbed your toe, or like Naman who's gone running, has hurt his toe, you're going to start to walk differently, right? You start to limp. And after a few weeks, other things start to get achy. So your knee starts to get achy, or your hip starts to get achy, you get back pain. And these are things that people don't link up to. Actually, if your feet aren't happy, the rest of you starts to fall apart as well. And so this is where I think people don't look at, when patients are getting these complex pain issues, well, why? Well, actually, if they can't actually put their feet down on the ground, how can you expect them to go through a gait cycle where the joints should be taking the weight correctly and the pressure point being? How's that going to work? You've also got the other thing that no one really talks about is scar tissue contractures. So any of the abdominal surgeries, head and neck surgery, again, mobility issues, you can't bend, you can't move side to side. Again, can you see how when you're walking, you can't distribute your weight from one foot to the other? And no one really talks about this, but particularly the pelvic one. So your pelvic has to tilt for most of your gait cycle in a posterior tilt, so it has to tilt backwards. If it doesn't, your feet start to flatten off more, and so you're putting pressure more on the insides of your knees and the feet, and again, you're getting these joint pain issues. So there's a few things. So musculoskeletal, which really doesn't get talked about. You get a little bit of exposure with the dermatology in terms of chemotherapy, but neurology as well. Again, patients are just told to live with it, and actually there's lots you can do around it,
So very complicated, lots of aspects of it. I suppose I'm going to have to ask the question that I'm sure people are thinking is, why doesn't every cancer patient have access to this?
That is a really good question, Nan. I don't know why. It's not just cancer patients, it's rheumatology patients. All these patients who get similar kind of... so one of the cancer drugs is methotrexate, right? That's used for rheumatology patients. They get the same side effects. Exactly the same skin effects, nail effects. Why is it not exposed? Diabetes seems to have a really good exposure to podiatry. But again, also it's to do with commissioning of services. I don't think people realise what podiatry does or the value of it. Or sometimes it gets fobbed off as... there is a hierarchy. So anything to do with healthcare in terms of the head and upper body seems to get a lot more spending cap to it than anything below. And people just get on with it, don't they? So... And also, slightly negative, my professions don't talk about it. We don't promote it as well as other professions. It's not talked about from school leavers age, but, you'll see the school dentist or the school optometrist, but they don't do any foot checks. Even at the, when babies are being checked, there's no actual screening, guidelines, even about giving advice about footwear. So it's a really poor topic, and I don't know why, because actually... other countries, you look at Australia and America, it's a really common place to have podiatry. It's a really valued service. And I think some of that is also due to, sadly, private insurances actually know the cost it makes to the economy if your person at work can't work because they can't move around on their feet. It's a huge economic difference. And so, again, sadly, money talks, doesn't it? And we don't live in that society where everything's free at the point of delivery, which is great. But I think we don't then take the optics of actually, if you can't move, what does that have on the welfare of the state and the impact it has on that?
What advice would you give to, I'm thinking, clinical nurse specialists, therapeutic radiographers who are maybe coming into contact with oncology patients more frequently? What can we do to almost promote podiatrists, but also help and support our patients to recognise when maybe they do need that referral or that intervention?
So one of the easiest ways is I've wrote loads of literature, so just go on my website in terms of clinically, they can read exactly what podiatry does, what kind of conditions. It gives you a bit of a kind of overview. I've made it so that anyone can read it, whether you're a podiatrist or other clinicians. Because it gives you an idea of what you're looking for. Does that make sense? So that's the first thing. In terms of the second thing is actually saying, even if you don't see someone like myself who's a cancer specialist, getting them to see a podiatrist is crucial. Because even if they've got nothing else, they can do baseline checks of vascular, they can do basic checks of neurology, so they can keep an eye on it. So if things are changing, while they might not be able to cope with that change, they can flag it up to oncology, so need to alter drugs or whatever it is, or be put into the right system. So that's one of the things. And in terms of just actually telling patients, actually this is one of the side effects, because again, that's also, patients get worried, is this a side effect of the treatment? Is there another cancer complication? Is this another form of cancer? Especially when you look at ulcerations under the nail, because it granulates and it becomes it looks like slightly like a raised tumour type site, because it is proliferation of cells, so technically it is, but it's not a cancer. But that can actually be quite scary for a patient, so actually reassuring them, this is to do with the drugs, don't worry, see a podiatrist, because even if you're not seeing someone like myself, even if they're able to deal with some of the basic wound care, that makes a huge difference to that patient, just getting them to be able to move. So that's what I would recommend. And also, I suppose particularly just reading around the subject. So if you do see something, you can read around it. So just, again, my articles, and I wrote stuff for Macmillan on their Learning Hub as well, so there is stuff out there. And it's not like you have to become an expert in it, just have the awareness that there are skin conditions. The basics are, yes, you get skin issues, you get nail issues, that can affect your walking, and you get neurology issues. But see someone about it, see the podiatrist, even if it's in private practice, or, that's where I would work with.
Obviously, with all the social media posts we did last week, there were quite a few comments and people reaching out to you. I think one of them was around what people can do prior to going for chemotherapy. Obviously, it's going to be quite complicated for you to make an assessment, but what are some of the things that they should be considering?
So one of the things to consider is making sure your skin is in its best possible condition. So making sure it stays hydrated. That's the first thing you could do. The other thing is so my pain management role, which is, not so much podiatry, but actually what I do find is the role of B vitamins. Actually making sure you're getting the right nutrition, particularly in B vitamins. So what I've seen in a few papers is actually patients don't get tested for anemias like pernicious anemia, which is B12, before they start treatment, and then they have the treatment and then their B12 is plummeted. And again, that will cause neuropathy issues. But actually another one that people don't get checked is B6 and B5. So B6 helps with nausea. So while that doesn't seem like it would affect us, but actually if you're feeling nauseous, you're not going to eat properly. If you're not eating the right amount of proteins, you're not able to feed the body and actually help the body heal. So again, also protein has a huge impact in terms of helping absorb other vitamins as well. So again, making sure diet-wise you're eating to the best possible ability before you start your chemo. Before you also start is also just see a podiatrist, get your nails checked, because you might have already be suffering from, say, the runner's toe, the ingrown toenails, or hard skin issues. Getting that sorted before you get onto that chemotherapy cycle will help. And again, footwear, right? Making sure you're on the right type of footwear, and not being told by people like when you are in foot pain, just wear flip flops. It's not going to help the situation. So.
Does that mean that people shouldn't wear Crocs either?
Crocs are fine for a little while, but not for all the time.
Should be banned just from a style perspective.
I think so, especially with the socks.
Or when people wear socks and sliders.
Yeah.
So that's a professional. If anyone's listening, socks and sliders is a no.
No, and also, perfect example, sliders, right? The first thing you start to do is grip your toes, right? So if you're gripping your toes, if you're on chemotherapy, the chemotherapy drug starts to leach out from your skin. And so if you're getting areas of higher friction, such as those toe areas, you can imagine that chemotherapy drug starts to leach out on there. It's going to create a toxin reaction on the skin there. So you are going to get sore feet just on terms of the toes. It's a simple, you wouldn't realise the footwear link, but actually huge impact on those chemotherapy patients. So no wearing to the sliders. Wear something with some kind of ankle support. So if you want to go for the hiking sandal, with a strap across the front and the ankle when it's summer, absolutely, that's fine. Just nothing that causes that slipping friction motion, because again, that rubbing is going to irritate your skin, especially when your skin's more fragile.
And Afni, in terms of kind of supporting patients from a rehabilitation perspective, so I'm thinking there's lots of patients now who may never have considered anything to do with their feet or their hands, or from a dermatology perspective as a long-term side effect of cancer treatments. What should we be advising patients? Is it to get in touch with podiatrists if
Get
they've
in
got
touch
any
with
long-lasting
podiatry, get
side
those nails
effects?
under control, because again, that long-term effect, you know, we're talking about the fungal nails and the thickened toenails. Well, you don't think that's going to be, that's fine to manage when you're in your 40s, 50s. Once you start getting into your 70s, 80s, actually that's really hard to even get down to your feet to cut your toenails. You know, around about 50, 60, that's when, you know, people have had back issues, all sorts start to happen. But also that's when your vascular system starts to, you know, slow down, degenerate. So you're ready. Once you've got those thickened nails, there's not as much we can do. Whereas actually getting it more, even though it's later effects, and you may have had, it's get it as soon as you can. Does that make sense? So getting that dermatology looked at. But also, I mean, sometimes patients think like you need to see us weekly. It's not like physio or seeing the osteopath or chiropractor. You're not seeing us weekly. You know, you might have to see me 6 weeks initially, every 6 weeks, you know, just to get it under control. But then afterwards, you're seeing me 2 to 3 months' time. And some of my patients, it's 6 monthly, and some of mine are yearly, right? So we do an MOT check, like you do for your teeth. In my clinic, I'm very much an advocate, because when I'm doing that check, I'm checking for moles. Are they looking cancerous? Are they looking different? Looking for skin conditions. Are they changing? What's going on with your circulation? What's going on with the nails? What's going on with your walk? You know, you might have had a sprain in between. That's actually caused a joint restriction. Right, okay, let's have a quick look at that and make sure that's, you know, keeping you moving.
You do a lot more than I ever stereotypically assumed a podiatrist will do. Hence why this is going to be so valuable to anyone listening.
And also, I mean, some of the pain management side in terms of the walking issues, that is very much a very complex pain management thing. And I use adaptive polarity and anatomy and motion and kinesiology and muscle testing. I know we've sent some, you know, you'll see in the pictures as well what I've been doing in terms of our like postings. But in terms of podiatry, it's still so broad in terms of the skin, the nails, there are so many conditions. And again, cancer affects patients who aren't, it's never just cancer is their only condition. They will have other conditions plus cancer. And I think people forget it's the other conditions that have a much more knock-on impact as well as the cancer treatment. So that patient may have arthritis or rheumatoid arthritis, you know, you've got rheumatology issues. They might have diabetes. They might have connective tissue disorders or hypermobility issues. You know, it's not just the cancer. It's cancer plus all the other conditions. That's why it has such an impact, I think, on patients.
Afni, you mentioned about different like conditions. So I think, if anyone knows me, quite interested in skin tone differences and stuff. I know this is something you've actually been talking about for quite a while, and now dermatology is catching up. But what are some of the differences in? I know we showed a few pictures last week, but how would you describe the differences of some of the reactions across skin tones?
Yeah, so so one of the ones I've noticed, particularly in my personal side of things, is Casita-B, used for breast cancer patients a lot. What I find personally is the Afro-Caribbean and the Asian population particularly get much more severe effects and much more quickly into their cycles. So often the Caucasian skin cycles, it tends to be cycle 4 or 5, and it's not really talked about. Even when I've looked at literature, it's not really mentioned about the kind of the skin tones. So that's one thing. So they get a much more severe reaction, but much more quickly. And I don't know whether it's genetically we're not able to process the same kind of levels in our livers or kidneys. You know, I know in like the Aboriginal cultures, alcohol is not able to be processed as easily, so they get much more toxin type reactions there. But it's never really talked about. So again, the skin condition, as you saw in the pictures, it looks completely different. That everyone says, oh, clinically it's that bright red, like as if your skin's been painted, stained red. Well, that Asian skin tone didn't look like it was going to be painted red. It's much more like as if it's been stained in a bluish ink, right? A blue purple ink. So that's one thing. Nails look slightly different on our Asian tone. So what we see is like our nails are much more they have a slight blue undertone in the nails compared to Caucasian skin as well. So again, what might start people going, oh, that's looking a bit more bluish in the Caucasian skin. Actually, that's actually looking more sinister in an Asian skin. So again, not really documented, but I think my level of experience in this area is what allows me to do it. But also the other thing that no one talks about, keloid scars. right? Keloid scars have a huge impact, and you see it in radiotherapy, right? And the scar contracture around a keloid scar is far greater in terms of the joint movement. And remember I was saying about that joint movement, if you're getting a so I think my post that's come out, is it today on the MSK ones? And I show the person, the little mannequin with the scar contracture on their shoulder. So imagine if that's Asian or Afro-Caribbean, they get a much more keloid scar. Can you see how that contracture is far deeper? So again, that's going to even reduce the mobility on that shoulder level. That's going to put much more impact on the hip. So again, same thing with the pelvic issues and the keloid scars around there, or even like leg stuff as well. So there's that, this kind of ethnic minority, actually there's a lot more impact on them. And also I don't know, because you can never tell on when there's these drug studies that are done, it never really talks about the makeup, the genetic makeup of these patients. Like how many were Caucasian, how many were Asian. And again, some of these articles I'm a bit more critical with, because statistically they're not significant. Doing a study on 30, 40 people, that's actually not significant, because if you look at statistical data, actually need to be in the 100,000s to actually get a proper sample size of that kind of level of treatment. So while we're talking about journals and stuff going, oh yes, there's this journal and that journal has said this, well actually you've got a very small sample size, so many other variables that they've not even talked about, like the ethnicity, like the genetics around it. And again, mixed race as well, that's going to change the genetics, even when we're not even talking about that side of things, because how does that react? So I think that is really important to actually start to pick up in journals, and even actually having better case studies. So while it might not seem relevant, actually having better case studies on these patients actually has a huge impact, because you can actually do much more reflective learning about it, and taking it forward, what you can do to help those patients. Particularly like the keloid scar is a big one in my pain management clinic. I see a lot of that, and there's lots we can do around it, and actually helping that joint move and get better outcomes in the range of motion you're getting with it. But it's not talked about. So yeah, I keep raising awareness, and we do need a much more embracive approach, and not just, oh yes, we see patients and then just stick the picture of, yes, a person of a certain colour, that's what you see. It's not like that. You really need to get to know the skin and how it changes and what's going on with it, and being able to understand the different colour hues, and actually, so what might be red for one person actually more purplish blues on another skin tone.
The irony in all of this is we keep talking about personalised care, but we're obviously not delivering personalised care. It's part of the NHS plan, it's the buzzwords, but we've never really been doing it.
My personal opinion is I think we've become less personalised than ever before, because everything's becoming processed, and no one's actually taken into all the clinical details that you need to listen to and look at. We hear constantly, you go into the GP, it's one person, one problem. Well, actually, I've never met a condition where it's one symptom. It's when you put X, Y, and Z together, then you get the full picture, and then you can say, oh, it's this condition. So it's really difficult for me to, and I was trained, where when I was trained, you had to know what the root cause of the problem. It was never just accepted, oh, well, it's just this, put this on. Why has it happened? And I suppose that has always followed through in my work, and that is very much my ethos, is why is this happening to you, and has allowed me to do what I do. But yeah, it's personalised care. You need to listen to the patient, and actually the patient matters, and what matters to the patient might not necessarily be what you're thinking is the important thing. Such as, if you can't put your shoes on and take your kids for a school run, or go and do the washing up, or stand and see your friends, or go out for dinner, what's the point of going through the treatment, because you've not got much of a life from it and you're in pain? There's the quality of life. And again, I think instead of personalised care, I think what needs to be is, can you improve that patient's quality of life?
Really, really good points, I think. I think quality of life is something we've heard on the podcast or through engagement on social media. Lots of patients will be told, well, the cancer's gone, or, well, you're alive, just deal with it yourself. But quality of life is something I think we don't really consider necessarily, not all the time. I think we try to, But it's all the different elements, exactly as you said, like all the different filters for someone's life. It's not just having treatment and going home.
And also some of these, cancer is also, it affects anyone at any age. Whether you're a grandparent or, elderly, seeing, your kids or your grandkids growing up to. So I've had patients who, when they were a teenager, had sarcomas on their legs and now having these complex pain issues on the hip and the knee and the foot and the neck. And it's because no one's actually looked at, when you have that sarcoma, what was the scar contracture going on? How was that joint moving? Or you've not got that joint there anymore, right? You've got a replacement joint. That has a knock-on impact on your quality of life, And we know, if someone's had a hip operation or a knee operation, it's 10 years' time, you might need it changed, or 15 years. Well, if you've had that at 15, that's a huge impact, isn't it, on your development and further on later on as you grow older.
So, Afni, we're coming towards the end, but I wanted to ask you before we finish, what's next for you? So you've been working clinically for a little bit.
Yeah, well, as anyone knows me, I love my job. So this is the bit that drives me, is I don't want any patient to suffer. So I will always try and help anyone, or even if they do come and ask me for advice, I will try my hardest. Clinically, ideally what my area is actually just getting more promotion and actually have get a good educational module together would be fantastic for this area of cancer, this acute area of cancer. I think is really important, and again, trying to raise as much awareness about it, really. So passing on, if you see someone who's got these conditions, even if you don't know, just send them information on it is the way forward. And also, I know it sounds awful, but for clinicians, is campaigning to the universities, actually these things do matter, and also try and raise clinical funding. But again, because I'm private practice, it's so much harder for us to get any kind of recognition or funding on any of these conditions. So even when I wrote my articles, that was a huge sacrifice I had to make just to get there and get that out there. So yeah, I think initially it's clinically, but my future plan is, as I get older, I don't want this knowledge to be wasted, and I want it to be passed on and change, and actually make proper change, rather than just talk about, like you were saying, Naman, in the NHS, the buzzword terms, but we still don't get any lower limb assessments done. They get an upper limb assessment when they have in their pre-cab stage, but there is no lower limb assessment done, or even what criteria or what potential issues could happen in the lower limb. I don't think there's literature around it, what the impact it can have on you.
Well, hopefully that will be something for some of our listeners to take away and look into. So, Afni, do you have any top tips for patients, students, professionals listening?
So for patients, see a podiatrist. Just start your journey, see a podiatrist. It doesn't matter if they don't have the cancer specialist, as long as they've got a decent understanding. Ring them, ask them questions, what they do. You'll get a good idea of whether that practitioner is the right practitioner for you. And also, not everyone, find a practitioner that works for you. Does that make sense? That's more of a teamwork-ish thing, not just, if it's not working, find someone where it can work with better. So that's for patients. Making sure their nutrition's, and in terms of nutrition, I know we've talked about making sure that they're already starting to get as healthy as possible, because even when you're going through particular cycles, you're not going to feel well, you're not going to want to eat in the same way. So getting that kind of stored up, kind of better level of nutrition is good. In terms of clinicians, I think my thing is find your passion and go with it. Really, just find it, and it doesn't matter that you feel like you're hitting your head against a brick wall. It will eventually. I mean, I've been doing this 18 years and advocating it, and now it's finally coming to the forefront. Just if you're passionate about it, it will happen. And it's okay for clinicians to say, I don't know. I think that's really important, that we as clinicians say, I don't know, that looks really interesting, but I don't know. I can try and find out about it, but I don't know. You might need to see so-and-so. And also doing that referral and knowing what's available in terms of who you can refer to, not just in the NHS, but also privately, because you shouldn't be choosing what the patient's entitled to. They have that choice of they want to use and what services they want to go for.
Perfect. Thank you so much. And I think from anyone listening, thank you for all your hard work advocating for this. It's been great to have got to know you, and sounds like Jo's already got some emails primed to send to you to try and collaborate.
I am absolutely over you, Afni. I'm trying to think of how I can link in.
No, I'm really glad that you guys understand and like really happy to like raise this, because we've been talking about it for a while now, haven't we? That this is an area that affects not just one area of a particular cancer condition, it's across the whole board. And even while you think it's only small pockets in each individual cancer, actually together it's a much bigger impact than it is for other people.
Exactly. So yeah, well, thank you everyone for listening to Rad Chat. So your hosts today have been Julka-Anderson and Jo McNamara. If you're utilising the podcast for CPD purposes, consider the reflective questions posted, along with the links to resources and literature that we've discussed. To receive your accredited CPD certificate, please complete the Google form linked with the podcast. So thank you very much for listening, and make sure you check out all of our wonderful content over social media. Thanks.
Oh, amazing.
Was that good?
Yeah.